Good afternoon, dear our people of the ECHO sessions. You are welcome to the 76th session of ECHO since we started. And I'm excited to tell you that this year, this is the 25th session that we have had. The main topic today, if you have been wondering about why blood does not clot, the answers are right here in this room. I am very excited and looking forward to this discussion about the approach to coagulopathies, including DICs and HUS. With me is a panel of specialists from different fields, and I would welcome them to introduce themselves. If we could start with you, Dr. Ivan.
Okay, thank you so much. My name is Dr. Keera Fuuna Ivan. I work in Mulago. I'm glad to be here.
Thank you, Dr. Ivan, for making it here. Could we also hear the female on the team? My old friend, Dr. Mary.
Hi, everyone. My name is Mary Ellen Lyon. I am an emergency medicine doctor. I teach in the Master's of Emergency Medicine program at MakCHS University, and then work with the students clinically at Mulago National Referral Hospital. And I'm very glad to be here. The 25th, this is exciting.
Yes.
It's like momentous.
Cool. We will also hear from one of our own, Miss Rose.
Hi everyone, my name is Rosa Nakiganda. I'm a nurse at the surgery. I'm glad to be here. My first time here.
Okay, we will shortly be joined by Dr. Okello. He's just around the corner, but we will also be taking care of your questions and your questions on the chat. And there we have Dr. Oriba. Please take a chance to introduce yourself.
Thank you. Thank you very much. I'm Dr. Dan Oriba Langoya. I'm the head of Department Internal Medicine, St. Mary's Hospital, Lacor, and also an honorary lecturer with Gulu University. Thank you very much.
Perfect. We also welcome you all on chat, and I know that more people are joining. Please tell them that they are about to miss the most important session of the year. All right, so we are going to start with a pre-test as a norm here, but we would also love to take your expectations. Please use the chat and write the expectations, and please take the next few minutes to answer the questions that will be popping up. We will be glad to follow your expectations and read them and see that we align them with what we have prepared. So not distracting you in case you would love to air out your expectation. I will give a chance to one or two to hear your voices. We expect a very interactive session. So please put up your hand. I will be able to see it, and you will tell us the expectation. Good luck in the pre-test.
We want to focus on the questions to focus.
Okay, is there anyone who wants to talk to us? I see people are already very active. Sarah, thank you. And Mary. Anyone who would love to talk to us about their expectation? We need an arm up. We have about 2 minutes.
Someone's saying they submitted their expectation during registration.
What was that? Barbara, are you able to take us through your expectation? At least you have done it before. If you can unmute and tell us, would be very nice to hear from you.
Thank you very much. Good afternoon.
Good afternoon.
So basically, I personally would love to know the early identification. For example, when you're in A&E and you receive a patient who is critical, how do you know that it's a coagulopathy that is causing them to be in that state? And then the emergency management of such situations. Thank you.
Okay, our panelists, you had that. Okay, we keep it in mind and we will have to answer that. Anyone else? And look, you could put up your hand if you like. So I'll just check with the team if the pretest time is done. Should be in the next few seconds. Right. So I would love that we proceed with our long-awaited session. I hope we enjoyed the pretest. Let's see what you have written through the session. At this moment, I would love to welcome Dr. Ivan to take us through the presentation of a case that we will be dealing with this afternoon. Dr. Ivan. Please, you can still take time to write your expectations or anything you would love to inform us as the sessions go on. Dr. Oriba, you are also on standby for anything that comes in the chat, and this is how we'll be running the session. So Dr. Ivan.
Thank you so much. Good afternoon, team. Good afternoon, colleagues and seniors. I will lead us through the case presentation for today. Next slide. Once again, my name is Dr. Keera Fuuna. I work with Mulago National Referral Hospital. So we received a 25-year-old female who came with a history of vomiting and passing of melena stools for 1 week. And this is NR, a 25-year-old female with a known chronic kidney disease, secondary to nephrotic syndrome for 1 year, and was also known pulmonary embolism patient who was on apixaban, who presented with non-bilous, non-projectile vomiting and passing of melena stools for 1 week associated with epigastric pains and fevers. She had a long-standing history of bilateral limb swelling, oliguria, and intermittent facial puffiness. She also had been on prednisolone, which she had actually suddenly stopped 1 week before the admission. So on primary survey, the airway was patent. Assessing the breathing, the patient was breathing in mild distress. The respiratory rate was 33 breaths per minute. SpO2 was 98% on room air, and she had bacillar crackles. And then on saturation, she had warm peripheries with a capillary fill time not documented, and she had moderate pallor. The BP was 91/58. The pulse rate was 136 beats per minute, which was thin and regular. And the heart sounds S1 and 2 were heard with a tachycardia. On disability, the patient was alert. GCS was 15 of 15. Pupils were equal and reactive to light with no focal neurological deficits. The initial RBS wasn't documented. And on exposure, there were no visible injuries. The temperature was 39.3 degrees Celsius, no rash, no skin rash, but with a facial puffiness, dehydration, diffuse petechiae, papilla, and grade 2 pitting edema. And on secondary survey, the head and neck were normal with no deformities and no injuries. The chest, there's obvious mild distress with bacillar crackles. The upper limbs were normal with no deformities. Next slide. The abdomen was normal, fullness, soft with generalized tenderness, and a tender hepatomegaly. The genitalia were normal. The lower limbs were also normal with no deformities. Then in the sample history, I've already talked about the signs and symptoms. Then there are no known allergies. She had been on medications, furosemide, apixaban, bisoprol, and prednisolone. And this is a known chronic kidney patient with nephrotic syndrome and pulmonary embolism. And she had had a meal 2 hours before the admission. And the attendants reported that she would get something to eat whenever she would actually request. So the problem list, we're having a 25-year-old female with a chronic kidney disease and pulmonary embolism with vomiting, melena stools, passing melena stools, fevers, tachycardia, and a hypotension. So in the investigations we did, the full blood count, the initial full blood count we did, the HB was 6.2 grams per deciliter, where the platelets were at 14. And the LFTs that we did, SG-GOT was a 5-fold increased, and then the GGT was 4-fold increased with a decreased serum protein and serum albumin. And the RFTs we have, urea was 8 times increased, creatinine was 5 times increased, and the potassium was normal. The estimated GFR was 9.6. And we also requested for prothrombin time and extended serum electrolytes. So in the management, we gave IV omeprazole, 20 milligrams OD, IV metronidazole, 500 milligrams TDS. We gave flucamox, 1 gram BD, prothrombin complex concentrate, 2,000 international units, tranexamic acid, 1 gram TDS, vitamin K, IM, 10 milligrams, and transfused the patient with 3 units of platelets and 2 units of packed red blood cells. And as part of the follow-up, we did an RDS eventually and 19.6 millimoles per liter, and immediately gave Actrapid 5 international units start and kept monitoring the RDS. We also gave albumin 20%, BD, and restarted the patient on the prednisolone 50 milligrams OD. Other investigations that we did, we asked for were the PTI-NR, blood culture, early morning cortisol levels, and also consulted the hematology and the nephrology team. Meanwhile, unfortunately, our patient passed on before we can have all that review done. Thank you.
Wow. Thank you, Dr. Ivan. I hope we all got the case presentation, and we can already figure out what was going on. And this is going to be the main focus of this discussion. We have been joined by Dr. Okello. You will please take the pleasure to introduce yourself. And then we are very critical, and we are also keen on you taking us through the etiologies, the clinical presentations, evaluation, and some investigations for this patient.
Yeah, thank you so much, listeners, and thank you, audience. Here we are, yes. The topic is well clear, approach to coagulopathies, including DIC and HISv. As you have already been told, my name is Clement Okello. I am a hematologist and I work at the Uganda Cancer Institute. I'm very happy to be participating in this forum. Yeah, so really, the outline of our presentation is really on common etiologies, as you say, clinical presentation and investigations. Later, then we'll go into other aspects of management. And so moving forward, really, the slide. So what is really the so-called coagulopathies?
Yeah.
Coagulopathy really is bleeding disorders. It's a condition in which the body does not form clots. And so by itself, it's really bleeding disorder, you say like that. And there are so many aspects to that. But before we list so many causes, these coagulopathies mainly applies to the factors that control the bleeding. As you know, in the body, there are so many things that will lead to control of bleeding. But what this spectrum talks about, those conditions that are brought about by those factors, the soluble factors in the blood, that's the problem. And so what are the causes therefore? The causes can be divided into congenital causes and acquired causes. What are the congenital causes that we know? One of them is sex-linked cause, and that is hemophilia. There are two forms of hemophilia, hemophilia A and hemophilia B. These conditions are present in our community, and there are so many patients who have that. There are other non-sex-linked inherited disorders, also called autosomal disorders. Those are, for example, the von Willebrand disease, again, very common, but rarely diagnosed in our communities because, again, some specific lab tests are required for it. And then there are those other factors, the coagulation systems, you can call them factor 1, factor 5, and so many Roman numerals up to factor 12 or 13 that tend to be deficient. And then there are others, you can combine those factors. And then there is also what we call hypofibrinogenemias. The fibrin that form clot tend to be lacking. You might have the fibrins, but at the same time,
So apologies about that. We have just sorted out and now we are ready to go. We could continue, Doctor.
yeah, thank you. So we were talking about the causes of coagulopathies being divided into acquired and then congenital, and we were just summarizing on those other autosomal inherited disorders, which were a defect of the fibrinogen in the body. And so we wanted to move to the acquired causes. In these acquired causes, again, there are those that are due to liver impairments, the liver failures. As you know, the liver produces coagulation factors. So in liver disease, you might have a coagulopathy, and then you might actually have those factors in the body, but then for some reason they get consumed, what we call consumptive coagulopathies, where now DIC, which we are going to talk about, really fall under. So the coagulation factors are there, but they just get eaten up for some reason, and then you present with bleeding. There are also other immune-mediated syndromes where von Willebrand and other acquired hemophilia fall. And then there are others as well that fall into N deficiency. Again, in Wells tumor, there's what we call again also von Willebrand. So those are kind of acquired causes, but don't forget that the drugs that sometimes we give patients actually present with bleeding, and most of them are the drugs that help to treat blood clots. You know, so many like the rat poison called warfarin. There are other fancy drugs for treating blood clots called factor 10 or DOACs, rivaroxaban, and all the likes, including heparins. So when you over-anticoagulate patients, you throw them into bleeding syndromes, and therefore these are all coagulopathies, the bleeding disorders, and that's where we are. And so for our focus today, really, because you see that coagulopathies are so many, we will just go and dive into the DIC to inform our discussion this evening. That's where we are going. And maybe we can talk about other coagulopathies that are presented by the, or grouped under TMAs, thrombotic microangiopathy, where HUS fall. And so let's go into now DIC. What is really disseminated intravascular coagulopathy? So this is an acquired syndrome, and it is characterized by systemic activation of coagulation within the small vessels in the body. That is what really happens. It's activation of the clotting system in all the blood vessels that supplies every organ in the body. And so this leads into this microvascular damage. Once it is damaged, there's also going to be organ dysfunction, because then there's hypoxia. And then if all these clotting factors get consumed, that's why some people call this really consumptive coagulopathies, then it throws the patient into bleeding, so it will present with hemorrhage. By and large, this is how you would look at DIC, activation of the coagulations within the vasculatures, leading into organ failures, and then bleeding at the same time. It is triggered by either infection or non-infection related causes. By and large, infectious causes, also called sepsis, is the most frequent cause of this DIC. Then you would ask, what would be the prevalence of DIC in patients who present with infection? It varies according to the studies you go through, different cohorts in different jurisdictions. They give quite a wide spectrum that spans approximately from 18% to even up to 40%. That's really an approximate figure. But what is common among them is that the mortality attributed to sepsis-related DIC is universally more than 30% in all aspects. So that is DIC. And what are the etiologies? In other words, what causes these things that is called DIC? Infection is by far the commonest cause in our communities. Of course, cancer is one of those. And if you look at that circle that is there, the green looks at the cancer, it's up to 26%. Followed closely, or actually by the same margin, 25% of infectious related etiologies. Then you can come to the trauma and obstetric causes, where you can go into liver disease and all the other complications of disorders. But on your right, left, rather, you can specify them that really vascular deformities also come in, severe immunological reactions, and these are usually provoked by some fancy new therapies that we have, the targeted or immunotherapies. They can actually throw patients into DICs if you're not careful. So some of these medications, once they're prescribed, they also have their side effects. We are lucky that we are not in a place that has so much heat, extreme heat. So heat stroke actually leads to DIC as well in places that have temperatures above 40 degrees. They also cause DIC. That is really, in terms of the etiologies, what are the possible causes? There are so many others. Now, how does it happen? How do these conditions actually lead into DIC? What you see in front of you, it really shows you that the causes or pathophysiology of DIC is not any single factor. It is multifactorial. It is complex. And as you see that it involves an interplay of all those related factors that can span from the patient's own factors, the triggers as well. And so going around the cycle, you see there's what we call endotheliopathy. So inside the vessel, the endothelial surface, once it gets activated, once it gets destroyed, there are factors in there that interact with the population. Yeah, so it interacts with, again, the coagulation factors in the system. As you know, what coagulation pathways you have, intrinsic and extrinsic pathways, they also interplay there to cause DIC in the center. Platelets themselves, once the platelets get activated, aggregation, adhesion into the endothelium and into the actually the pathogen, they end up causing the DIC, including every aspect of inflammation, the systemic inflammation that comes with all its cytokines lead into DIC, including the complement system and then the fibrinolytic system. And some of those we will go ahead in the next slides to actually see how they come about. So those are so many aspects. But let's just see how, for example, DIC actually is triggered in terms of the initiation of the coagulation in DIC. The channel there takes us inside the blood vessel, the microvasculature. And in the microvasculature, if you look from upwards, you see that some pathogens actually get into the vascular circulation. So the bacteria, for example, there can be viruses, and there can be some dead cells that would come from maybe trauma and all other obstetric causes you might like it to, including malignancies. So once all these get into the blood system, the way the body reacts to it in such a way that the blood cells, first called the monocytes, that also include the macrophages, sense these through their receptor molecules. And once they perceive this, it stimulates them to release the tissue factors. And these are the tissue factors, as we know, what the intrinsic pathways are, the extrinsic pathways of coagulation. This trigger the thrombin formation. And as you go towards the right, you see that at the center of it, there's formation of thrombin through the tissue factor pathways. But at the same time, once the dead cells release what we call the cell-free DNA that comes into play, interacts with the cells in there. So on the surface of the organisms, the pathogens actually, they can actually stimulate what's called the contact pathway activation. That is actually the intrinsic pathways of blood clots. And so all these need to form thrombin. Thrombin is a very essential aspect of development of DIC. And thrombin, as you know, leads into other platelets activation that again goes into fibrin formation. Once you have the fibrin, they get stabilized, more fibrin forms, and then the thrombus comes. Now, if the blood vessel is so small, that actually can act to impede the blood flow and so causes hypoxia that will lead to organ damage. That is essentially how the initiation of DIC comes about. You have the pathogen, you have the trigger in terms of tumor and all those other things causing DIC. But once that is also started, the body propagates this DIC. It amplifies DIC. You don't only have the monocytes in the system, but you also have neutrophils. And so the neutrophils actually propagates DIC. It amplifies DIC. Thank you very much. And so how does it do that? There's what we call the neutrophil extracellular traps. As you think of the traps, it's a net. So the product of those neutrophil extracellular traps, the molecules, actually feed into the fibrin formation. And so you have the nucleosome, the cell-free DNA that again triggers the contact pathway activation. And some of them actually, for example, the histones, that's the endothelial excitation to release the globules, for example, that the way they collect molecules or body that trigger the formation of vulnerable factors against that comes into clot formation in the DIC. But it again leads us to the same fibrin formation, thrombus formation, and then that's where we end up. So everything keeps repeating itself in the entire body. And so once that is amplified, we go into then, once we form the clot, we go into now, the body will want to fight the clot. And how does the body fight the clot? It's in the next slide. So there's what we call fibrinolytic modulation of DIC. It means once there is no blood flow, the body wants to open up the blood flow by eating up this blood clot. And so that the blood flows. And that is where now the fibrinolytic pathway comes in. There's an enzyme that does that. It's called plasmin. Plasmin, remember, when a patient gets, and again, this is emergency medicine, once a patient gets into acute PE, there is the medicine that we give to thrombolize, to break out the blood clot. That actually is an analog to tissue plasminogen activator. That breaks plasminogen to form plasmin, so that once you have the plasmin, then the clot gets eaten up. So once the clot is eaten up, then you have the fibrin degradation products. That includes actually D-dimers. So then this is where the D-dimers comes about. That's why we talk about D-dimers in DIC. It is very central. And these processes, including the initiation, amplification of DIC, including fibrinolysis of DIC, again, they are closely regulated. And once that is that, everything really tends to go to that. And so this is where the D-dimers comes about. Next. And so once that is done, there are two phenotypes of DIC. There's a DIC that presents with blood clots, and there's a DIC that presents with bleeding. So it's also called DIC with thrombotic phenotype. This DIC is mainly from the infection-related sepsis. And so once that is that, there's a systemic inflammation, there's endothelial injury that leads into increased coagulation. decreased anticoagulation factors, including decreased fibrinolytic factors, the D-dimers and those other things. All this leads into thrombin formation, which we have already talked to earlier, and most of these cause microvascular thrombosis and organ failure. But again, at the same time, when the clotting factors gets consumed, some patients might present with bleeding, but by and large, the sepsis tend to lead to organ failure from microthrombosis. The other phenotype is fibrinolytic phenotype, because DIC with fibrinolytic phenotype. This one comes really in trauma, and APL is acute thrombocytic leukemias. So this again causes systemic fibrinolysis. And so most of them leads to increased fibrinolysis, that is basically what happens, to the point that increased D-dimers is always seen in other fibrin degradation products. And so these tend to go into the bleeding, but most of them, over 30% of these conditions lead into mortality, death. And so our next slide, again, now goes into how would the patient present. And our case actually today had most of these. And because most of them cause microvascular thrombosis, organ failure, kidney failure is one of them. Whatever organ you can think about, even the brain and all the organs get spoiled. Gangrenes, because there's no vascularization, so most of those things die off, including pulmonary thrombosis as well. Now, for those that will present with bleeding, you can imagine all sorts of bleeding. In the skin, you can have petechia, you have ecchymosis, completely all branching of the skin that you see. Some of them actually can present with what is called necrotizing papilla, or you might think rotten skin. Mucosal bleeding can come from anywhere, gastrointestinal, urinary, mouth, and all those other things. All bleedings will come in, but if you bleed into those vital organs, for example, the brain, including adrenals, again, that's when all these things come about. The other features of hypotension, which our patient had, is also one of them. Shortness of breath, confusion is also in the equation. And so this is in terms of the clinical presentation. And so how do we investigate these patients? Investigation of patients for DIC is really easy, and most labs should be able to do it, but not all. The commonest that you need to do is a complete blood cell count, because there's going to be low platelets count. If the patient has bleeding, therefore there's bound to be some anemia as well. This is just what you need to look at. Of course, the other aspects of how do you investigate the etiology now depends on what you're investigating. Then the other next investigation is a peripheral blood smear exam. Once you advise the hematologist, that's what they will ask you. We want to see features of microvascular angiopathy, hemolysis, schistocyte. That's what you see in the peripheral smear. And so there's the test for bleeding, the global test for bleeding. The commonest that we do in the town here, PT, INR, whatever it is, these tend to be prolonged. Sometimes you can do APTT as well. These by far are the three tests that you should actually order if the patient has no bleeding and if the patient is actually having no thrombosis. You see, you can actually ask for this in any setting. But if the patient comes with bleeding and is in the ICU, you can actually ask for all the five, including fibrinogen levels, which you naturally have it low because of consumption. You now know that once you ask for the D-dimers, it will be high. This by far are the only 5 tests specific to DIC. But remember, on your right, none of these tests is highly sensitive or specific. When you're asking for this test to make a diagnosis of DIC, you need to evaluate the clinical context. And so you can never be sure, say, this is what and that. So you have to put all this in. So that's what I'm saying, that there's no single lab test that can accurately confirm or eliminate the DIC. We can make the diagnosis of DIC in count, and these are the only tests you can do. But remember, you need to do the other tests for the etiology. If the sepsis, know what is causing the sepsis, and so on and so on, and including other organ targeted tests, the kidney function and the rest. That's in terms of investigation. So how do you actually come to make a conclusive diagnosis of DIC with all these results? There are other scoring systems, many of them, but most importantly is that International Society on Thrombosis and Hemostasis, ISTH, is that overt criteria for DIC, and it's based on the platelet count, D-dimers, thrombin time, fibrinogen levels. And if you get a score of more than 5, you're most likely to have DIC. That is overt DIC. There's the DIC, which is, you call it sepsis-induced coagulation. It's also called compensated DIC. That is on the extreme. So if you're suspecting DIC and it's not yet very overt, again, it goes in the same, but you only need a score of more than 4. You just suspect DIC. If it's less than that, you're likely to be DIC. The one in the middle is good for the Japanese score. Most of them are really validated, but not so many centers really use them. But these are the scoring system if you have to do to make a diagnosis of DIC. Yes, we're coming to the end. The next slide really, yes, the next slide. That is it. So how do you now bring DIC and other thrombotic microangiopathies? There was some mention about HUS. Most of them present almost in the same way, but there are some differences. The biggest difference is that other thrombotic microangiopathies, including TTP, HUS, rarely present with consumptive coagulopathies, if you want to call it that way. So if you do the fibrinogen levels, the bleeding factor, tests including PT, INR, most of them tend to be normal. But in DIC, once you see that all those are low, then you know that that is DIC. And then those other TMS, most of them actually have clear causes. For example, you can document TTP is mostly caused by the deficiency of Adams 13 protease, which again cleave the von Willebrand. But in this sense, most of them, the von Willebrand factors are so big, and so it mops up the platelets. HUS, for example, the one which is complement mediated, again, it's a complement issue. But the other ones that is infection associated with sugar, toxin mediated is really because of infection. And so both DIC and other TMS can produce microangiopathy. So if you ask for them in a lab test, the peripheral smear, they tend to be the same. This is really to touch slightly onto the HUS so that you make sure that we have actually touched that. But that is it about HUS really. And so the next slide therefore tells us that, yeah, this is in terms of the etiology, how does it happen, what really happens if you dive a little bit into the vessels, into the position of DIC. And so this should bring us now into the knowledge of how do we assess the patient, how do we manage the patient. And so I thank you.
Wow. People in the room here feel like clapping for Dr. Okello, the man who decided to invest his time into treating and recognizing diseases that come through blood, bone marrows, and he is indeed a very hard man to find. So we thank ECHO program, the Ministry of Health, and SIP Global for giving us the opportunity to have you here. Now, going back to our 25-year-old who we are discussing today, in this room, just like Maximilian on the chat said, this is going to be a hard nut to crack. We want to make it simpler and have a discussion, and we are very keen at hearing from a professional, from a star in the emergency department, Dr. Mary And we would love to hear from you how you would approach this patient and what are the possibilities of treating or managing this patient.
Great. Hello, everyone. I thought rather than, have more slides or anything, that this would be more of a conversation today, just about the recognition and management of these disorders. And so I'm hoping we can kind of go back and forth here, because I don't have a lot of experience dealing with them in this setting, which, and that's always, you always have to take care of a particular patient in a particular place at a particular time, right? And so the setting in which we care for our patients is an important factor in the management always. So I'm hoping we can, kind of talk through a bit what it's gonna look like to take care of these patients. And in the meantime, I think the first thing I'm going to think about when I'm in the emergency department is just a patient comes in that is in some way sick, that I'm worried about. What is the first thing that I'm going to do? And the first thing is going to be that initial evaluation, right? We can never get away from that primary survey, we call it, right? So I'm gonna get to the patient, and I want to evaluate that classic sort of ABCDE workup that we talk about over and over in emergency medicine. I want to check on their airway and see if that's clear, if that tube is clear from the outside world into their lungs, right? To see, are they breathing? Are their lungs coming in and out? Is oxygen getting from their lungs into their bloodstream, right? And circulation, looking for any signs of hypoperfusion, whether that's their capillary refill time, their blood pressure, if someone's able to get vital signs while you're making this quick assessment. Are they cool? Are they, kind of clamped down on their periphery? And then their neurological status. Anybody you don't have to have any reason for it all. Anyone with any kind of altered mental status needs to have their glucose checked. And if you can't check their glucose, just give them some dextrose, because the great mimic in emergency medicine is hypoglycemia. It can look like anything. It can look like alcohol intoxication. It can look like DIC. It can look like anything. So if somebody comes in and they're not on top of the game mentally, check their glucose. If you can't, give them a little bit of sugar just to make sure that it's not that. And then check their neuro otherwise, and then everything else, looking for wounds, looking for any reason that might account for what you're seeing in the patient, right? So that's a whirlwind of the primary survey, but it's absolutely absolutely critical to remember that. You do not have to have any idea what's going on with the patient to do that. The point of the primary survey is you're going in having no idea of anything, and rather than standing there thinking, gosh, this could be, what could it be? What do I need to order? Don't do any of that. Just check the airway. Is the tube open? Check the breathing. Are the lungs moving in and out? Do they have two lungs or only one lung? You hear sounds on both sides, right? So just always remember, it doesn't matter what topic it is this week or next week or 5 years from now, when a patient comes in and you have any reason to be worried about them, A, and then B, and then C, right? And once you know that you've got a little bit of time, if you don't find anything that you have to intervene on from that immediate primary survey, then you can take a breath and try to figure out exactly what's going on, yeah? I think the patients that makes most sense to talk about today, again, because we focus on emergency medicine here, are the ones who are going to come in the sickest, right? The really acute case of a coagulopathy, right? Somebody who comes in likely bleeding, right? So a severe DIC that's going to come into the emergency department is likely going to be, they may have like bruising all over, we think about like purpura, like big splotches of really pathologic bruising. They may actually be bleeding from several areas, certainly the mucosa they tend to be. They may be having bleeding from any number of places. So multiple bleeding sites is a strong indicator that you're looking at some kind of coagulopathy. Now, one of the big drivers, one of the underlying things to remember with DIC is that it is a syndrome, right? It's not a disease. It is something that is caused by other things, right? So very often, as we've talked about, sepsis, right? So sepsis, malignancy, trauma, like a polytrauma patient or bad traumatic brain injury, either of those can lead to I lost my voice. I hope you all can hear. I hope you all can hear me.
You're doing well, you're doing well. You have swung into action while behind. Continue.
Trauma can do it, obstetric complications, right? There's some of the more common and unfortunate complications of childbirth and the aftermath can lead to DIC, right? So DIC isn't a disease that you catch that we can fix. It is a syndrome that is being triggered by something else going on. So you always want to remember, you're not going to get on top of DIC unless you're addressing the underlying problem. If the problem is that this person has sepsis, you've got to address the sepsis at the same time you're trying to catch up with and deal with the coagulopathy itself, right? That's fair to say, I think. Yeah. And why I thought of that is I work at Mulago where we see a lot of trauma, right? So I have patients come in who are bleeding from a lot of different places for traumatic reasons, right? But not to say that a trauma patient, just to always remember, it's why we do these sessions, to always remember that bad trauma can lead to DIC. So if a patient is continuing to bleed, even after I feel like it should have stopped, their blood should have clotted by now, right? It's not a hemorrhagic bleed, for goodness sake. If it's a venous bleed, it should clot off and stop. If it doesn't, remember, we could be looking at like a DIC picture, even in a trauma patient who you expect to be bleeding to some extent, yeah? So we've got a patient that's come in. They're sick, they're bleeding from different places, like the mucosal bleeds, there may be mouth, there may be the nose, there may be, from the rectum, where bleeding from multiple places, right? And we aren't sure what's causing it. We've talked, we've heard rather this morning about some of the ways to try to figure out what's going on there, like, is this DIC? Some of the labs that we can get. For me, we're fortunate because most of us carry a computer in our pockets these days, which makes practicing medicine a lot easier because you can look it up. But one of the ways that I remember these things, if I can I get up and draw on the board?
Please.
Okay, I love drawing the board.
You cannot avoid the teacher and you and we have the opportunity to
I'm not
learn.
happy if I can't draw on the board, okay?
Yes.
Okay. So here's how I think about these coagulopathy things. Like, the body is designed to be able to stop bleeding when it wants to, right? But if you have like say a tank of water, right, that has like a pipe going out here and then I don't know, faucet of some kind, I'm really not an artist, okay? So, and this is H2O, right? So you've got a water tank here. If this pipe develops, oh my gosh, this is a permanent marker. These are markers, not whiteboard markers.
It's okay.
Okay, all right. So if this pipe develops a leak, right, then even if it's a tiny leak, this tank will eventually empty completely, right? Because this pipe isn't going to fix itself and the water isn't going to magically stop dripping, right? It's just going to keep dripping, yeah, forever until it empties, right? But this, fortunately, is not the way our body works, right? So we have our vessels here, yeah? And when we get, which happens all the time, I mean, I bump into things all the time, I end up with bruises, I'm clumsy, that's just the way it goes. So we get a break in the vessel here, and we start bleeding, right? Ha, genius blood drops there, can you see what I'm doing? So what happens? So we've got all these like platelets swimming around in the blood, right? How many times a day to those of us, you get a CBC that tells you about platelets. All these platelets are swimming around and they're like, whoa, there's a wound here, okay? And so they stick to it. All this, I don't know, it's been a long time since I've been in med school. The point is the platelets stick to the wound, right? So they start sticking here and make like a temporary clot, right? So, and it's like a cork in the bottle. It stops the blood from leaking. It stops the germs from getting in. It's super temporary, but hey, it works, right? And then meantime, the whole system is calling in the big guns, right? So the big guns are over here with this like thrombin thing and this fibrinogen thing, and these two dudes, which I'm misspelling entirely, these two dudes get together and you end up with fibrin, which comes along here and joins its little platelet pals here, and that's when they get serious about the repair, right? Now you're like breaking up the wound, right? For realsies, yeah? Making a hard clot, this fibrin platelet clot, really like takes care of the system until the vessel can do that like magic, oh my gosh, how does that happen thing of repairing itself, right? And over time, as the vessel actually literally repairs itself and becomes the wall again, then the fibrin clot goes away. Does that make sense? So the point is, this system is meant to happen when something happens, when you have a thing. In these consumptive coagulopathies, as Dr. Okello was telling us about, the problem is this whole system gets keyed off and it just starts clotting up everywhere, consuming all the thrombin, consuming all the fibrinogen, consuming all the platelets, even though there's nothing to repair, right? So that when there is something to repair, there's no bricks left. There's no platelets left to form a clot. There's no fibrinogen left to brick things up here. The problem is, the reason you end up bleeding is because we all constantly spontaneously have little breaks in our vessels, right? The reason patients bleed pathologically in these coagulopathies is because the things they need to stop bleeding are all gone. They've just been taken up, clotting everywhere else in the body that doesn't actually need clotting, right? And that's why some of the labs that we were just hearing about, that's why like your platelets are going to be low, because they've just been pointlessly consumed by this syndrome that got kicked off by sepsis, by cancer, by bad trauma, by the fat embolism that can happen sometimes in pregnancy, right? So you're going to have low platelets. You're going to have low fibrinogen, because that's one of our big guns over here that got made low, right? So those are the way I remember that these labs are going to be low is by remembering this. The whole problem, the whole thing that disseminated intravascular coagulopathy means, it's disseminated all over your body. Things are coagulating that don't need to be, right? And eating up all the stuff that you need where you actually have breaks in the vessels. And that's why so that's why, as Dr. Okello mentioned, you can have thrombotic presentation where all of those clots that are being formed cause problems, right? Your 25-year-old Dr. Ivan had PEs, right? So she's got clots in her lungs. This is not good, right? And you can get certainly clots in your coronary arteries. That's what we call a heart attack, right? So forming clots when you don't need to is bad on its own, right? So you can have thrombotic complications from this problem, or you can have once it's all clotted up, you can have the bleeding problem, which is when you run out of these ingredients and you need them. And that's how patients come in bleeding from several sides, and they can't stop bleeding because their body does not, it's like this pipe over here that can't fix itself, right? The water can't clot. The pipe can't magically fix itself. You don't have the ingredients anymore that you need to stop bleeding. So even a relatively minor bleed, ordinarily, like we see sometimes in our hemophilia patients who also can't bleed for different reasons, can't stop bleeding for different reasons. Even a minor injury can turn into something life-threatening if your blood can't clot like it's supposed to, right? So if you're concerned about the possibility of DIC or of a coagulopathy, you can get these labs, right? One of the things that you're going to have is just a flat out anemia, right? The patient's going to have probably less hemoglobin, fewer red blood cells as everything gets consumed, and then you're going to have your low platelets and your low fibrinogen. Yeah. So what we're going to do about that? This is what I want to talk about, because I don't know what it's like where everyone else practices, but where I am at Mulago, I can get labs. The lab's open 24 hours a day. I can't get labs quickly, right? I can't get labs in the kind of time I need them to deal with a patient who may be bleeding to death. Yeah, and I'm not sure if that's true. I'm not sure if that's true for everyone else, but I wouldn't be surprised, right? The sort of instant lab work and like getting it, where I initially trained, you could order the labs and then the answer comes up on your computer, a few minutes later and it's super handy. We just don't really have that here, right? So I think the question here in terms of management becomes, we're gonna have to just evaluate, we're gonna please draw some labs, send them to the lab so you can get some answers eventually. But if we've got a critical patient, we're gonna have to intervene before we actually have those labs. So I'd like to draw you in, if you don't mind, Dr. Okello, on this conversation. My feeling is, and this would be even, I think where I, as I mentioned, where I trained in the United States, where I'm more likely to be able to get labs right away. Oh, my pictures are already away. Pictures. If somebody comes in and we can usually get a CBC right away, my feeling is active bleeding and low platelets give some platelets. But I mean, there's some talk in the community about there's certain conditions that are sort of similar to DIC, like the hemolytic uremia syndrome, which we can talk about if we have a bit of time. And TTP, there's a few of these related syndromes where there's at least some chance that actually giving platelets could maybe make it worse, but I feel like in a situation where you are not able to get comprehensive labs and definitively decide why your patient's bleeding, then if you have a patient who is actively bleeding under dangerous bleed and has low platelets, give them platelets. What do you think?
Absolutely, yeah, so
Okay.
that's very true. So when you get platelets in a bleeding patient, we know that if you're suspecting DIC, really platelets is not doing, the cutoff is usually about 50, but in the event that someone is bleeding and you think it's related to platelets, give platelets.
Just give platelets.
Absolutely.
Right.
That's okay.
Yeah. So as with so much of like emergency medicine, you treat what's in front of you, right? So let's say the patient is bleeding, I'm not sure what's going on. One of the labs I tend to be able to get quite quickly is CBC, I usually can. So if my patient is bleeding, I'm not able to get, and I know they have low platelets, I'm gonna give some platelets if you can get hold of them. Then, some of the other labs that we talked about getting, there's the sort of the coagulation labs, if you have the prolonged PT, prothrombin time, or the PTT, if those are looking longer. And then you're getting into some of the blood products like, fresh frozen plasma, things like that. What I'm wondering is if those are prolonged, and again, you haven't been able to make a definitive diagnosis. One of the things we can get hold of here, we usually get hold of some vitamin K. Does that do anything for you as an emergency treatment in this setting? Do you think?
Yes, absolutely. That is the vitamin K dependent factors. I mean, you would increase, but if you're suspecting definitely low factor levels, frozen plasma is generously available.
Yeah.
Just go ahead and give.
Yeah. This is the thing. I think, if you're feeling like somebody has this pathological bleed, it's just not adding up. You haven't been able to get great labs to figure exactly what's going on, but they're just bleeding and continuing to ooze in a way that isn't normal. Then the one thing that has most of what you're going to need, give some platelets and see if you can get hold of some fresh frozen plasma. Yeah, because that's going to have most of what's needed. And most of the blood banks that you're drawing from should have the plasma, I believe. Is that true generally across Uganda, would you say?
Not generally countywide, but we have quite a number of frozen plasma units available, but they are not so much used, but definitely the products are few that we have frozen plasma.
What if you're someplace where, and this is a question I've had in the back of my head, I'm glad to do this because I'm learning in real time as well. What if you're someplace where you can get whole blood, but you can't get the fresh frozen plasma? Is the whole blood going to be of any use in a coagulopathy like this?
No.
Or related just to consuming
Not so much,
yet?
really not so much, because the percentage of those coagulation factors in the whole blood is not that enough to provide bleeding. However, if someone is bleeding and you think that actually giving blood helps, there's what we call in anemia demodulation. So you push back the platelets, you want to increase the blood volume, so you cause some bit of coagulation and prevents the bleeding.
Okay, yeah. So there again, we're talking, I mean, we're trying to be very practical here because I don't want to pretend like everybody's going to be able to get a full set of 10 different coagulation labs right away. You've got a patient who comes in, who's bleeding, you're worried, if you can get a CBC and you see that their platelets are low, give them some platelets. But in general, if a patient comes in and they are bleeding, then they're getting into a hypovolemic state, if they need blood, give them blood, because if you're in a more, if you're in an area where you're not gonna be able to get to a specialist, and that's what these patients need, what you need to do is buy some time to get a referral to a higher level of care, right? And if a patient is bleeding to death in front of you, they need blood. Now, they may not be able to clot that blood the way that, you're not solving the coagulopathy problem, but you might be buying them enough time to get to the specialist who's going to be able to do a more definitive workup and a more targeted treatment with these more specialized blood products. Yeah, does that make sense? And the other thing that I would say that I meant to say at the beginning and just didn't, which is the whole reason we need blood, right? The reason we need blood going around is because we need oxygen getting to the tissues, right? We need oxygen to get to the brain and the heart primarily, but really the whole body needs oxygen. That's the whole point of blood, right? It's why if somebody's bleeding a lot from trauma, you might be able to give them a little bit of fluid just to keep things circulating, but what they need is blood because normal saline and lactated ringers don't have red blood cells. And red blood cells is what carries the oxygen to the tissues, right? So in these patients, any patient that comes in that's bleeding a lot, what you're seeing is oxygen spilling out onto the bed and the floor, oxygen that their body needs. So put these patients on oxygen, okay? Give them as much oxygen as you can so that whatever blood they have, as much blood as they have circulating in their body, all of those red blood cells have as much oxygen in them as possible, right? So most patients that you worry about when they come in critically ill, septic, a lot of trauma, all these things, one of the first things to do really, give them a little bit of oxygen. The chances of oxygen hurting them are surpassingly low, right? So give these patients some oxygen to help with as much blood as they still have going around. We want to get as much as we can to the tissues. Get the labs as best you can. If they have low platelets, give them some platelets. If you can get fresh frozen plasma, beautiful. If you can't, and you're really having a bad bleed, like a life-threatening bleed, give them some blood, buy some time, and get on the phone to somebody who's going to be able to direct this care more specifically, like to a specialist, yeah? And what I would say, the other thing I would say about that is I really want to encourage everyone who works in emergency medicine, in an acute care setting, any frontline health worker, never be worried or concerned about or hesitant or embarrassed about calling a specialist for help, right? We are not specialists, we're generalists in the best possible sense. Right? We take care of patients from the cradle to the grave. We take care of them when they come in renal failure, when they come in with heart problems, when they come in with neuro problems, when they come in from boat accidents. We take care of everyone. So we know a lot about everything, but not everything about everything. That's why specialists exist, right? And God bless them. They chose to get super specialized about this thing and know everything about this one thing. And so what you and I need to know, we need to know enough to recognize, whoa, we might have a coagulopathy going on here. Stabilize the patient as best you can, buy them some time, little oxygen, little blood, whatever you can get them, and then get on the phone to a specialist who can help you guide the care. Because we are not, as frontline health workers, meant to be able to handle the details of these complicated coagulopathies. We need to recognize this may be what's going on, treat what we're seeing in front of us, and figure out who is the next doctor to take over the care here, yeah? And so don't ever hesitate to reach out to the specialist. Every conversation I have with a consultant, I'm the dumb one, right? Because the reason I'm calling them is that I don't know as much about cardiology or hematology or neurosurgery as they do. But I know a lot about all those other things, right? So I'm never embarrassed to say to a cardiologist, yeah, I'm not sure about this EKG. Because meanwhile, the next 4 patients I take care of are in completely different fields, and I'm fine with that too. So reach out to specialists, be happy to say, I don't know this. I've done this, I did my part, what's next? And how and when can I get the patient to you? Yeah.
Wow.
Happy Wednesday.
Thank you, Dr. Mary. No. We have benefited a
I go
lot.
fast.
We have benefited a lot from the session so far. And you have tried to break it in the easiest possible ways. And I know it's a big topic that we are all learning from. But yes, we are lucky that we have you all on the panel. We would love to open up this discussion to you, team, if you have any questions. And particularly, we also want to hear from you so that you can talk to us. And we see if we can relay some of the answers or get some of your ideas about this case or cases that are similar to the one we are discussing now. Just raise up your hand and we will take you on. I also want to thank Dr. Oriba. He's doing a great job on the chat.
Yes.
There have been questions coming up and he's handling them so well. In the background, I was asking the specialists and Dr. Okello said you're doing a good job. Cool. We will take up hands and take your questions, please. Give us some energy. We want to hear from you if you are rhyming with us. If you fail to see the feature for putting up a hand, you can as well unmute and comment or ask.
Maybe we just explained everything and there are no questions left.
Yeah.
No.
That
Yes, I wanted to ask the question.
Okay.
I was wondering whether we managed to get the profile picture for this patient, the clotting picture for this patient, the APTT and the PT we had ordered, or PTNL. And also the other question I had is what could have triggered the DIC, if that's what we're thinking about in this patient? What could be the trigger? Thank you.
This is Robert from?
This is Sanawe Robert Gayaza.
Okay, thank you for participating. We will take one or more questions so that we can give you feedback at once. Do we have any other questions or comments?
Hello.
Yes, please.
Hello, Mayor. Yeah, I'd like to ask a question. Yeah,
Please.
thank you for the presentation. Hello, this is Eric Moyan. I'm interested. I would like to know if there is a benefit to using all the prothrombin complex, FFPs, vitamin K at the same time in event of somebody presenting with DIC or any other coagulopathies. Should you be worried of putting them into actually clotting and they end up with thrombosis in their lung and they die from that? Thank you.
Okay, thank you, Eric. The question is taken. I am sure they will know who will answer what. We want to take two questions, probably. Go ahead. There is a hand from Olara. Please ask.
Yes, thank you so much, the panelists. I would love to ask how best can we maneuver? I've heard doctor when he was presenting the use of dextrose. How can we maneuver with patients with DM at our facility? Yes, thank you.
All right. Are we able to take one more? Good. We have a few minutes. We will take one more question and then get some responses. We thank you so much for the active participation. You could also use the chat, that's okay. But I would love one to speak to us. All right, so we can, oh, we have a hand from Mutegeki Adolf. Please go ahead.
Okay, thank you very much, Tim. My question is one. When I was in Kawempe in the NICU, I used to see those neonates, or I say prematures, are prone to bleeding. So just I want to inquire what could be the triggering? What could be the triggering factors? Thank you.
Bleeding chance. I think we have enough questions so far. We will get another opportunity as we keep our time well to get more questions. Who is going to take what? The case presenter, some of the questions were directed to you, but you have a whole resource here. You could try.
I think let me make a response, and then my seniors will come in as well.
All right.
So about the PT INR profile for this patient, we're not able to get it on time before the patient passed on, but we are taking off the samples. So we're not able to appreciate to look at it. Then about the trigger for the DIC, this patient, this is a patient with nephrotic syndrome and chronic kidney disease. And also he was on apixaban for quite a long time because we were managing pulmonary embolism. So from the discussion that we've seen, someone who's been losing, was losing the proteins through urine and losing blood definitely, you could imagine that a lot of clotting factors were also lost in the process. And also, we're not able to ascertain whether this was a complete DIC. And then we just think that this was a mixed picture of maybe hemolytic uremic syndrome together with maybe DIC, though we're not able to confirm whether it is actually DIC in this case. But I want to invite Dr. Okello to comment on this. Thank you.
Yeah, thank you, Doctor, and I thank the person who asked this question really. This patient was a complex patient. It's not a classical case of DIC by definition. There were so many things that were happening. But if you remember very well, I think this patient had some sort of fever. And when you have fever, your speculation is it might be some sort of infection. And we have talked about infection as the commonest cause of DIC. It might be over DIC, but it might have also been because of other bleeding aspects, including complications of the apixaban and the rest causing just coagulopathy. Yeah, so it was a patient that needed a bit of more workup. If you have these other clotting factors, you would say yes, they are low or not. Yeah, thank you so much, the person who asked this question. There's that question that asked actually that was asked about FFP, PCC, vitamin K,
binary.
Leading to possibility of clots.
Yeah, the possibility of throwing this patient from bleeding to clots or from clots to worsening of the clot. That would apply so much onto the vitamin K. I mean, you see, when you give vitamin K, you're thinking that the vitamin K dependent factors that with vitamin K would actually come and form the clot. And usually give vitamin K to reverse the side effects or the over anticoagulation of the warfarin, the rat poison we talked about that causes coagulopathy. But we can also actually give vitamin K if we think there's some bit of inappropriate secretion from the liver failures. And that's why if the patient just comes to you with these bleeding disorders that you actually don't know, you have a safe bet because you don't have anything. And I like the way Dr. Mary Lyon put it up. She didn't go into really the best way of managing these patients with DIC. She came from the practical point of view that if you happen to be from, for example, a Beam hospital where I come from, you don't have all this luxury, but you might actually have vitamin K. Why don't you try and it works? The concern, therefore, if you go into higher centers, is if you give them, they want you to throw out this patient into the clotting. Yes, those questions have been asked. And particularly if you want to give these patients things like tranexamic acid, sometimes if there are even questions actually that if you anticoagulate these patients now with the heparin, our patient got heparin and all those other things, won't you actually worsen the bleeding? So there are those whole theories, but get it that DIC is really a spectrum. So whom do you anticoagulate therefore? It is for that phenotype that comes with clotting. So you are actually safe, but make sure that there is no bleeding before you give actually anticoagulation treatment. Then the issue of fresh frozen plasma. As you know, fresh frozen plasma should have all the coagulation factors that actually, if you demonstrate and you have all the suspicion of this syndrome, that is more likely going to be DIC, your safe bet is frozen plasma because it has everything. It should fix you. But of course, you have to treat the other underlying condition, as Dr. Mary said. So that is very critical. What about this PCC, prothrombin complex concentrate? This you actually would give if you're worried that the patient has volume overload. And that is when you can now say, no, this patient has heart failure. You don't want to volume overload them. Therefore, keep away your frozen plasma. And the best bet would be now PCC, which is really concentrated clotting factors. That is indicated in DIC that should actually present with bleeding. So you fix the bleeding, but don't throw them into clotting. In any case, why would you worry to reverse the bleeding? I mean, you want to stop the bleeding. That is the most important, but treat the underlying condition as well.
There's a question from adults, if you remember, about bleeding in premature.
There is that as well. Unfortunately, we see every patient present differently. So there are so many other causes of bleeding in neonates, including hemolytic anemias, as you say. But most importantly, there's what we call this night alloimmune thrombocytopenia that happens in neonates. And so patients are just born, or kids are born with no platelets, and so they just bleed. So it's called NATES, neonatal alloimmune thrombocytopenia. That is just one of them, but there are many other causes of bleeding in neonates as well. We should hear more about that.
Very good. I told you that this is going to be one of the most important sessions that we have had this year. And Ms. Nakiganda, you are representing so many nurses that I've seen on the chart. I see Mildred, I see so many of them I cannot mention. But from your angle in the nursing, how would you approach this patient? I know it's kind of a hard question after all these presentations and all options, but we would love simply, how would you handle this 25-year-old?
All right. So my name is Rosa Nakiganda. I'm a nurse. I'm going to take us through the nursing care of a patient who comes in with DIC or coagulopathies. So, in my point of view, when a patient presents at the ED, the first person that approaches them is the nurse. And examine the patient, taking the primary survey according to the patient that has presented to you. And in that, we do the vitals, and I think that has been already explained, the first slide that you have presented. Yeah. Is there another one? Yes. Yes, so we do the nursing assessments. And in the nursing assessments, we are taking the subjective and objective data, depending on how the patient has presented to us. Dr. Okello has already presented the signs and symptoms, so we are not going to dwell so much on them. But as you can see, as nurses, we have nursing goals. So in this, we want our patient to maintain optimal gas exchange. That is the FiO2, the SpO2 should be at least above 90, but it should be 90 to 100, but above 90. Below 90, we need to oxygenate this patient, give as much oxygen as the patient needs. We need to maintain optimal peripheral tissue perfusion. We need to experience reduced episodes of bleeding and hematomas. And then this patient, we need to experience reduced side effects of the medication. This patient, some patients get coagulopathies, not only at the ED, some patients are on the wards because we've been managing these patients. Maybe some patients are in the obstetric and this mother gives birth, she gets PPH and then develops DIC. So some of those patients are on the wards. But when the patients present to us, we need to manage the side effects of their medications. For example, if a patient has been given heparin, we need to manage the bleeding that will come with the heparin. If a patient has been given anticoagulants, we need to manage whatever side effects of the medication. And then the other thing, we need to maintain therapeutic levels of coagulopathy laboratories. And the lastly, the patient that we need to have a verbal understanding. This patient should be able to understand their condition, the condition they have. Because if the patient is able to understand the condition they have, they are able to report whatever new thing comes up. So in this, we need to the nursing interventions and actions. We want to promote effective gas exchange in this patient. We need to closely monitor the respiratory rates, the respiratory parameters, the SpO2. ABGs are very important in this patient, and oxygen. If we can have, if you are in a setting that where you can have capnographies, you can be able to monitor the patient's carbon dioxide levels, because you need to know, are these patients experiencing the carbon dioxide, their gas exchange at the level that you want it. And then we need to give supplemental oxygen depending on the patient's need. We need to position this patient. Patient probably has presented on their ward. You have assessed the patient is not breathing, having difficulty in breathing. We don't know the cause of the difficulty in breathing. So we need to position the patient according to their needs. We need to assess for changes in the levels of consciousness. This patient has presented to you, for example, patient has come to the ED and they are conscious. All of a sudden, they have lost consciousness. You want to know why this patient is losing consciousness, or depending on the other presentation that they have. Do they have the petechiae, the skin? You've examined the skin and probably you've noted that this patient might be having this DIC, and they have presented to the ED. They've lost consciousness. You want to know why. We need to assess the respiratory depth, the rate, and the rhythm. The low breathing, some of these patients, because of the hypoxia, they can have rapid and shallow breathing. So we need to assess all that. Then assess the breath sounds, assess off for signs of bloody sputum, If the patient is able to cough, look at the sputum and see, is there blood in this sputum? And then what could have been the cause? For example, the patient that have been presented had PE. Some of these patients who develop PE can also develop urinary edema. You can have, or whatever, blood in sputum. Then we need to assess the heart rate, shortness of breath. Some of these patients present with shortness of breath and use of accessory muscles. If this patient is using accessory muscles, what would have been the cause? Patient might be having difficulty in breathing. Patient might, because of the clotting bit, might have thrown a PE. We need to monitor the oxygen saturation and assess arterial gases. Then, after this, so this patient that has presented to us, we need, after monitoring and promoting the gas exchange, we've seen our patients is able to saturate well, is able to
Ekyanike sente ekyaki.
Yeah, is able to breathe well. So we need now to enhance the tissue perfusion. We need to see that this patient is perfusing well. And we are going to closely monitor the hemodynamics, the parameters, such as the blood pressure, the heart rate, the urine output. We need to see that this patient the blood pressure is within normal ranges. Because of bleeding, they tend to drop. But we need to see that this pressure is within normal ranges. If we need to give medication or we need to give IV fluids, then we do that. Then we need to resuscitate our patient with fluids if it is needed. Assess the chest pain, the patient for chest pain. We need to locate the location of the chest pain, the severity and radiation. Some of these patients present to the ED. Maybe they have been at home with the condition and the clot has already moved to the heart. And we have a bleeding disorder. At the same time, we have maybe an MI. So we need to know where is the chest pain. Is it within areas where we suspect MI? Some patients present with central chest pain. So we need to know all that. So we need to ask the patient and find out the severity, the location, the radiation, and if there is any shortness of breath. Then assess the amount of urine. Because when someone is bleeding, for example, but for the patient that we had, patient already had chronic kidney disease. The case presented, patient already had chronic kidney disease. So we expect that the patient has low urine. But if a patient has presented to the ED, or we have a patient in the wards and the patient has, maybe the urine output has changed, we need to closely monitor the urine output plus the color of the urine. Is there blood? Does it? Yeah, so we need to do all that. Then we need to assess the level of consciousness still, because as the patient continues to bleed, because the brain is now not getting enough nutrients because of the low volumes. So the volumes are concentrated in the organs that are very important to the body, but the brain is part of it, but it's not getting enough. Therefore, patient is losing consciousness. And given the fact that this patient is bleeding, that means there is hypoxia, the brain is not getting enough oxygen, the brain is not getting enough glucose. So there is hypoxia. You need to continuously assess the level of consciousness in this patient. Assess the ABGs, because they can they can be able to show us any as changes, acidotic changes, or yeah. Then monitor blood levels for this patient. These have already been talked about by the previous presenters, and position the patient in a semi-sitting up position, because if this patient is having difficulties in breathing, then a sitting up position is the best position for this patient, is if they are able to tolerate it. So we need to position the patient according to how they're able to tolerate, but the sitting up position would have been the best. Then administer oxygen therapy as necessary. If the patient needs, assess and then see the kind of mode of delivery that is necessary for this patient. If the patient needs intubation, still do that. We administer parenteral fluids as prescribed. So, please. Yes. So, and in all doing this, we are working hand in hand with the doctors and all the specialists, because some of these things the nurses do not make decisions. In fact, most of them, the nurses don't make decisions, but we have to work hand in hand. But given the fact that you are the person with the patient 24 hours, you need to be able to see or to assess that this patient's condition is changing, and then notify the doctor or whoever is attending to this patient, the physician. If it is a cardiologist, then notify the cardiologist, depending on how we have assessed the patient. So in this, we also, because one of our priorities was to prevent bleeding and risks of injury. So as we do that, we need to assess the underlying cause of coagulopathies. Was it trauma? Was it sepsis? Dr. Okello has already presented the underlying causes of DIC, so we're not going to dwell on that. And then as you assess the cause as you assess the underlying cause, we need to assess the heart rate and the blood pressure, observe for signs of aortic hypotension. This can also be caused by bleeding, by the low volumes that have been caused by bleeding. And then observe for signs of internal bleeding, such as pain, changes, yes. Observe for changes in level of consciousness, institute neurological checklists, observe for signs of internal bleeding from the GI and the G, and then note any hemolytic or blood obtained during suctioning. Examine the skin surface for any bleeding. Patient might have come with some, but assess if there are any more. Okay. Institute precautionary measures. In this, we want to reduce the things that can make the patient bleed more, like IM injection. You want to avoid IM injection because patient can easily form hematomas during IM injection, which will increase more clotting. We need to reduce unnecessary IV puncturing. If we are able to put a central line and do everything, giving blood, giving fluids and medication, and also drawing blood from the central line, that would be good. Provide gentle oral care for this patient. Normal saline instead of a toothbrush would work better. And then administer medications as prescribed, administer parenteral fluids as prescribed, and anticipate any needs for fluids as we assess the patient. Administer blood products as prescribed, red blood cells, FFPs, and platelets as needed. Yes, so as we take care of this patient, we need this patient also know the condition they are having. The condition they are having, that the patient will be able to adhere to medication, assess the patient's knowledge on the disease, carefully explain the understanding and cause of frustrated DIC, explain the purpose of drug and transfusions, and instruct the patient and the relatives to notify the nurse in case of any more bleeding at the IV site or any other. Maybe if the patient has a wound, we need to know if the wound is bleeding, is there blood coming out of the cannula or the central line? So we need to assess all that. As the patient, they are able to report that if you instruct them. Then we need to also prevent complications, potential complications. So monitor vital signs. Yeah, because we need to prevent potential complications, we monitor vital signs regularly. Usually it's between 2 to 4 hours, but in this case, we would want to bring it closer, probably to 30 minutes or every hour, depending on the patient's need and how they're presented. Then monitor the patient's cardiac rhythms, the ECGs, regularly to identify any arrhythmias, because this is a patient who is clotting. They are likely to develop PE or MI, so we need to know if this patient is still the way they came in, or have they improved or they are deteriorating. We need to assess the patient for neurological status. That is, we have already said that we institute neurological checklists, so we need to keep checking the patient's neurological status. If the patient is still at the ED, we need to still do that. If the patient has gone to the ward, we still need to do that. And also assess patient's respiratory status to help identify any signs of distress. Assess bleeding and clotting tendencies, monitor laboratory studies as ordered, and monitor fluid balance and ensure adequate tissue perfusion. Then we also need to assess the medication readiness and monitor potential side effects to the medication, depending on what medication this patient is. And then collaborate with the disciplinary teams, sharing information. If you have identified anything that is unusual on the patient, we need to report that to the necessary specialist, attending specialist, yes. And then provide information about the disease to the patient and the family.
Okay, thank you so very much, Ms. Rose, for that very elaborate approach from the nursing sector. I would love to open this up again for the last chance if there are any questions. I have seen a hand since we stopped taking on hand from Mukasa Gad. I don't know if your question is still burning. I would give you the opportunity to ask. And I also will have a question from the pre-hospital field. Now that I see many of my colleagues on, I have seen Tom Chove. This is a very special session. We would also want to know maybe from Dr. Mary from the emergency medicine. In this 25-year-old, what are those tips you would give an EMT who has been called to bring this patient to hospital? Are there any possible things they could really do to have a better outcome? And I would also want to ask Dr. Okello, looking at our scenario, we are not saying that they didn't do a good job or they did a very good job. From your opinion as experts, would there be something to save the young lady? So those two questions will be added to the ones we will get from the team. If you could get one or two or more right now. Mukasa. Okay, if your question was already answered in the discussions, that's okay. Do we have any more questions? Oh yeah, Oriba already answered your question. Thank you, Dr. Oriba. You're doing a very great job. Do we have any questions? Right, maybe one or two will come up as they discuss. Dr. Mary, you have an idea from a pre-hospital setting how best we would transport or move or care for these patients?
Yeah, you know, I know it always sounds like a broken record, but really in pre-hospital and often in the emergency department itself as well, you really just are limited to and really only need to just address what you see in front of you. You know, it's why we always go back to that basic evaluation of the airway, the breathing, the circulation, because you're just looking for, is there anything going on with this patient that I need to do? Are there secretions that I need to suction so that they can breathe, right?
Yes.
Do I need to give them, you know, do I need to give them some oxygen? Are they, you know, we talked about it, do they have a pneumothorax that's depressing their blood pressure, things like that. So I didn't, you know, in that presentation, nothing jumped out at me of something that someone missed. It sounded like this was unfortunately a gravely ill young woman, you know, from the start, who needed likely a multidisciplinary specialist team to address various things going on, because she was in particular a patient who unfortunately had different things going on. As Dr. Okello was just saying, one of the tricky things about these coagulopathies is they can cause a lot of clotting, which is a problem, and you might need to anticoagulate that. But they can also cause, because of the clotting, they can cause bleeding, in which case anticoagulation could only cause more bleeding. So there are no easy answers with these. And so at both pre-hospital and in the emergency department, outside of a specialized care unit or the treatment of a specialist, you really need to just focus on what you're seeing in front of you. What is going on for the patient right now? Is the patient hypoxic? Give some oxygen. Is the patient bleeding? Address the bleed. If you can't stop the bleed, maybe give platelets. If you can't get blood, you know, address what you see.
Address what you see is the key point that we should take. Dr. Okello.
Yeah, so I really don't know what could have saved this patient, because as Dr. Lyon suggested, this patient almost received everything. I mean, how many patients would you find receiving PCC in Kampala? So if it was DIC, I mean, they received PCC, should have reversed that. But again, this patient had so much to deal with that I don't know if that alone would have made her really any better. In terms of what next, I think we did the best, but keep in mind that 30% or above the patients with decompensated DIC really end up dying. So
everywhere in the world.
So much always really it's hard to deal with it, but some people come through it.
Thank you very much. I think we are left with a few minutes of this session. For those of you who are asking for the CPD link, it will be provided soon, and we will put it there so that you can benefit from it. I would only take one question. I want to risk the time. I hope we answer it in the shortest time possible. But Edwin, I will take your last question. Edwin Tindi.
Okay, thank you so much. Hope I'm loud enough.
Yes.
My name is Tindi Edwin Maruti, a student midwife at Lyon University. My question, and I think to be more of a concern, but I will need some clarity from Dr. who discussed DIC. Being a midwife, I am interested much in our pregnant women. And we usually see that in most cases, DIC in pregnant women is somewhat a life-threatening condition. So I wanted to, Doctor, in which trimester or in which stage of pregnancy should be scared of DIC in a pregnant mother, for example, after the diagnosis and we find that it is that? And then what do you think are the implications that the baby of this mother may face, including should we take it as an
Okay, I hope that is
manage
clear.
such a mother in a way that we can protect the baby? Yeah, thank you.
Okay, thank you. As brief as possible, we will give you some responses.
Yeah, thank you, Tindi. As you said, actually, the first question is which trimester is most likely to be the hotspot for this DIC in pregnant women? It's hard to say which, but just take it and reflect on what we said, what are the causes, what are the etiologies of DIC, and you come to know that sepsis or infection is one of those. And those infections, rarely would you get it from the early stages of pregnancy. Most times you get that at the point of delivery. If you want to say the third trimester, at that point of peripartum, it can come from C-section, come from badly handled normal vaginal deliveries. And so once you get infection there, it's a hotbed for DIC. But of course, this amniotic fluid and those other fragments around the perinatal period, those can also lead you into DIC. So in terms of the trimester, it might be really the third trimester that might be. And so is there any implication to the baby? Definitely what you need to do is to save life. And the good thing about the treatment for DIC, if you are talking about frozen plasma, PCC, they don't so much affect the baby. In any case, they will actually protect the baby from getting into crisis of bleeding on whatsoever. So you just treat the mother, save the patient, save what you see, save the situation in which you find yourself in.
Thank you so much. So my take home from that is that save the mother, you will save the baby. That's very important. All right, we really want to thank you so much for this big turn up, over 300 something participants that you have been discussing with. I would love to give an opportunity to all the panelists, and maybe starting with Oriba. Online, your last parting shots and what you give this audience as a last encouragement or point. Dr.
Thank you very much, Tim. Thank you very much, Tim, and for the wonderful deliberations that you have done. Dr. Okello, you have developed the pathophysiology very much, and Dr. Elaine has been excellent in making it very simple. And the case was also good. I am very happy. And I think what we can pick out here, if you forget the pathophysiology, please don't forget the clinical presentation, because it's very important in management of your patients. And Dr. Elaine has told you what you are supposed to do, you know, from the etiology, don't forget fibrinolytic versus thrombotic, or you can just say fibrinolytic or non-fibrinolytic, because that will tell you which kind of medication you are supposed to institute in your patients. And then on laboratory investigations, there is no single test, you know, in the laboratory that's going to make for you a diagnosis of DIC. You have seen so many scoring systems have been put in place. So you need to take good history from your patient, look at what is happening at the patient, while, you know, correlating with the etiology and overall thing, and you examine your patient very well, come up with a concrete diagnosis of DIC, and you start managing your patient. Of course, what has not been put a lot here is HUS. For HUS in our setting, two things, most common in children, and you know, it is probably, you know, sugar toxin, or even, you know, sugar toxin producing E. coli. So those are the two major etiologies. The genetical ones, we don't have evidence for it here because of research limitations. But this is an excellent presentation, and we can take that, we can manage our patients with DIC very well, basing on what has been presented. Otherwise, thank you very much, Tim, for inviting me on this panel. Thank you.
You, Dr. Oriba, you have been a great resource of this session. Ms. Rose.
Yes. My take home as nurses is we need to thoroughly assess our patients as we receive them. As patients come to us, we need to do the primary and secondary survey, assess the patients completely, so that you can be able to identify any underlying cause that you might have missed as the patient explains.
Thank you very much. Case presenter.
Yes, thank you so much.
You have given us a good base for discussion.
Thank you so much, the team online, the participants, and my senior colleagues here. I think for me, from this case, I learned that DIC, the moment you suspect a patient to be having DIC, then you already know you're behind the time to intervene. So it is such an emergency. That's what I learned from this case, because it doesn't give you an opportunity to do all the interventions and all the investigations that you need. Thank you.
All right, as I bring you the last two big discussants on the panel, I would love that my team posts the post-test so that you take it using the same time. We would love to see how much you have learned and if you have all our objectives met. I would start with you, Dr. Mary.
Yes, I'm not sure that I have a lot to add, except that I think it's just been a great session, and I appreciate all the questions and the engagement, and it just feels like it's been a very robust session in general. You know, from case presentation, our nursing colleagues, such a thorough presentation, and I think this is, at least in the weeks that I've seen, the most thorough chat question answering that we've had. Dr. Dan has just been running an absolute little clinic there on coagulopathies, so that's very impressive, and I just think it's great that everyone gets a chance to get their questions answered. I'm honored to be a part of it.
Thank you, Dr. Mary, and finally, from you, Dr. Okello.
Yeah, thank you so much. I first and foremost really thank the lively audience. It has been great working with you these few hours, and then the organizer really has been excellent. I like the way we have discussed and how actually I take on from the example of what Dr. Lyon just brings it to the simplest way of, if you're faced with this condition, wherever you are, just suspect it, do what you can. If you cannot handle it, please call a colleague who might give you a hand. In other words, don't be shy to refer. And really, I think that is the take home. Don't mind if you don't remember all those other pathophysiologies. It was just to give some hint. Just deal with what you have and see at the moment. Thank you.
Cool. So that was it with the topic today. I want to also interest you to attend the very last session of ECHO this year. It will be on the 20th December. It's a Friday around the same time. It's a hot topic also. Do not miss it. We will be talking about common cancer presentations, oncologic and chemotherapy emergency, if I mentioned it very well. In adults and children, please do not miss the session because it's going to be another fire in this very room. We will do one last thing. As we always do, I would request that we all put on our cameras and take a screenshot for this session. Meanwhile, as we do that, I will also want to continuously thank SIP Global, thank the Ministry of Health and all partners and all our panelists that have come throughout the year and since we started these ECHO sessions. Thank you so much for giving us the opportunity to learn a lot of things from the comfort of our areas, and thank you for reaching out to people that would take years to meet. I really thank you for that. And I thank all the participants who are always coming and attend and actively participate, all from the fields, doctors, physicians, EMTs, nurses, midwives. We are doing a great job. Right, I'm not very good at singing, but I hope in the last session we shall sing for you a Merry Christmas song. It's around December, and I hope they have taken the screenshot. It is 2 minutes past 4. We want to say thank you very much, and we end here. Bye.